comparing conservative medical care to spinal manipulation for chronic low back pain in older patients. We're always interested in comparison studies that pit one technique approach against another, rooting for our favorites and hoping for a clear winner. Well, a fairly recent study does just that, comparing regular diversified side posture adjusting to flexion traction, but it may not be entirely clear whether a winner can be called. The study is entitled A Randomized Controlled Trial Comparing Two Types of Spinal Manipulation and Minimal Conservative Medical Care for Adults 55 Years and Older with Subacute or Chronic Low Back Pain in the Journal of Manipulative and Physiological Therapeutics in 2009. So immediately we see how specific this study has chosen to focus: seniors with subacute or chronic low back pain. Let's see if the study participant inclusion and exclusion criteria narrow that down even further. For the inclusion criteria, participants had to be at least 55 years old, have nonspecific low back pain of at least 4 weeks duration, and meet the Quebec Task Force criteria of 1, 2, or 3. 1. Pain without radiation. 2. Pain plus radiation proximally. And 3. Pain with distal radiation. Exclusion criteria included patients who had low back pain with neurological findings, if they had comorbid conditions or general poor health, or major clinical depression, if they had bone or joint pathology that contraindicated spinal manipulative therapy, if they had a pacemaker, any litigation or receiving litigation payments, or having been treated with spinal manipulation in the prior month. So now we see that the focus is even tighter: senior patients with nonspecific subacute or chronic low back pain, which then excluded patients with known or perceived radiculopathy. Those doctors that use the flexion traction approach might call foul here because this latter patient population comprises a percentage of their caseload that they might feel is significant. Well, a legitimate complaint if the researchers were to extrapolate the results to patients with radiculopathy, but they did not. That will need to be another study. Most importantly, this study points out that the vast majority of patients with low back pain don't have radiculopathy regardless of radiation, even distally. This doesn't mean there is no disc pathology, but without neurologic deficits, radiation pain is likely referred. There was a total of 240 patients who were then randomized into 3 groups. The 3 groups were the high-velocity, low-amplitude manipulation group using a diversified side posture approach, the low-velocity, variable amplitude group using the Cox flexion traction approach, and the minimal conservative medical care group. There were 96 patients in the side posture group, 95 in the flexion traction group, and only 49 in the medical group. More on that later. For both manipulation groups, there was a maximum of 12 visits. Frequency was not to exceed 3 times per week for the first 2 weeks, 2 times per week for the 3rd and 4th weeks, and once per week during weeks 5 and 6. Manipulation was limited to the T12 through L5 spinal segments and SI joints. For the minimal conservative medical care group, participants were scheduled to meet with the medical provider at least 3 times during the 6 weeks during weeks 1, 3, and 6. Goals of management were pain improvement and keeping active, optimizing activities of daily living. Because pain medication was the, quote, conservative approach, the least potential risky drug was used first, acetaminophen. If patients did not improve, patients were then placed on NSAIDs, and only if these were ineffective were muscle relaxants used. In all treatment groups, the chiropractors or MD provided 30 minutes of standardized instructions for a home exercise program. The exercises were individualized to each patient based on their ability. The program began with the recommendation of an aerobic focus as well as low back stretching and strengthening exercises. Participants were given a handout with pictures of 7 low back exercises, with the number of sets and repetitions tailored and delineated for each participant. These exercises included the flutter kick, buttocks pinch, pillow squeeze, cat stretch, pelvic tilt, press-up extension, and double knee to chest. The primary focus in exercise prescription was to divide patients into categories of sedentary, mildly active, and moderately active. For patients who were sedentary, 5 to 10 minutes of walking was encouraged, with a couple of sets and only 5 reps of the low back exercises, while mildly active participants were encouraged to begin aerobic activity at 20 to 30 minutes 3 times per week, with an increase in sets and repetitions of the low back exercises, and with the moderately active participants adding in more sets and/or reps and more challenging low back exercises. The Rowland-Morris Disability Questionnaire was the primary outcome measure given at 3, 6, 12, and 24 weeks. Secondary outcome measures included the Fear Belief Avoidance Questionnaire, a 100-millimeter horizontal pain scale, and a global rating of improvement. Change scores of 2 to 3 points on the 24-item Rowland-Morris questionnaire have been recommended for sample size calculations for clinical trials. More on that later. One curious omission was the lack of measurement for patient compliance to their exercise prescription. Here are some interesting patient demographics for this study. The mean age of the patients was 63.1 years. 56% were male, 43% were retired, and 83% reported past use of chiropractic. 81% reported previous low back pain episodes, and 77% had been treated previously for their low back pain. 40% of participants were obese. Over 71% of the participants had been in pain for more than 1 year, and 15% had back pain with radiation to the distal extremity without neurologic signs. For any study of comparison, it's very important to know the following. What effect did treatment have on the outcome measure for each group individually? What effect did treatment have comparatively between groups, measured as mean differences? What degree of change in the outcome measure indicates a significant change, one that would be recognized by the participants? What are these changes at different points in time? This is important because for pain, a significant improvement earlier compared to natural history or another treatment group may be important regardless of what happens over longer periods of time, given patients may be more functional earlier, allowing return to work, for example. To determine effect, we need to know where participants started from. So what was the average score on the Rowland-Morris and the average pain score on the 100-millimeter visual analog scale at the beginning of the study? The Rowland-Morris was similar among groups, at a mean of around 5.7 to 6.6 with a standard deviation of 4. This is out of 24 points and reflects low disability. For pain, groups were similar at around 42 out of 100 and a standard deviation of 24. Quite a range. Let's look a little closer. Here's a table that illustrates differences between groups at different points in time. If we then also pay attention to the confidence intervals and p-values, we notice a couple of things. It appears that the two manipulation groups compared to the medical group showed decent improvement early on, as measured by the Rowland-Morris questionnaire. Almost all other stats suffer from poor p-values, wide confidence intervals, don't show much of a mean difference between groups, or all the above. Stated in the most positive way, participants who received either form of spinal manipulation were approximately 30 to 40% better on average in functional status than those who were in the medically managed group. However, there was no statistical difference between the two manipulation groups. A single low-velocity variable amplitude session was the application of up to 15 slow repetitions to patient tolerance in flexion traction. It's unclear whether a Cox protocol was followed or simply a flexion traction approach was utilized. We are unclear about the compliance rate for exercise for each group and all participants generally. Given this is the common thread among groups, it's an important missing feature. The number of patients in each group was not equal. The 2-to-1 allocation ratio resulting in a sample size of only 50 in the MC-MC group, which was about half of that in the two manipulation groups, limited the power to detect differences of 2.2 points recommended for clinical trials for the Rowland-Morris Disability Questionnaire. The power was lowered to 81%. Also of concern is the disproportionate dropout rate in the medical group, where 8 of 49 participants never visited the medical physician, and an additional 20% withdrew from treatment at some point over the 6-week active care period. In contrast, only 2 of 96 and 9 of 95 participants discontinued treatment in the manipulation group. The researchers were able to include 82% of the medical group because of at least one interaction. It would be interesting to know how a group of patients with radicular pain would respond to this same study approach, but this is not the focus of this study. It would also be interesting and important to know about confounding variables over the 24-week period, especially after the active treatment period. In that data, it would be very interesting to see the compliance rate for the exercise prescriptions so that if, for example, patients in the manipulation groups were more compliant, it may have affected the long-term outcome. All studies suffer from weaknesses. Regardless, though, this study is a well-constructed and well-executed one. Unfortunately, the results don't indicate a clear winner for either technique for seniors who have chronic low back pain. However, there is at least some statistical indication that either form of manipulation was superior to medical management. This is a good time to remind the listener, especially those who use either diversified side posture or flexion traction, that studies average out the results so that the occasional patient in practice who has a remarkable immediate response is not visible in the study results, but very visible to the doctor. The opposite is also true. The intent of studies is to look across a relatively large group to see, on average, what to expect as an outcome to an intervention. This is why your expert opinion is an important element of evidence-informed practice.